Median rheumatoid glossitis, as you can see in the figure, the median rheumatoid glossitis is typically seen in the middle part of the tongue. It is also called as a central papillary atrophy of the tongue, because as you see, this remaining areas are showing papillae, but the central area is not showing the papillae. So it was earlier thought to be a developmental defect, but later on, after it was shown that the treatment with the fungal infection helps in resolving the lesion, this etiology of developmental defect is no longer considered. So it's a pure candidal infection. So the etiology is by the candida, and more common in diabetic patients. It appears as ovoid or rhomboid shaped reddish patch on the dorsal surface of the tongue, mostly in the middle part of the tongue, and the surface is dusky red and completely devoid of papillae. The management is antifungal agents, and on long-standing cases, if it is not resolving, so prior surgery or excisional biopsy should be indicated, because in the differential diagnosis, even erythroplakia can be there. Therefore, considering that to be the differential diagnosis, if long-standing cases are not resolving, an excisional biopsy should be done. Next candida-associated lesion is angulocheilitis. At the angles of the mouth, the patients can have erythematous areas. The causes are mostly microorganisms, mechanical factors, nutritional deficiency, diseases of skin, and other factors. For the microorganisms, this angulocheilitis is considered to be a combination of fungal and bacterial infection. Therefore, in addition to fungal infection, other microorganisms could also be present. The mechanical factors can be like the patients who are completely edentulous. So they have creases at the corner of the mouth. So because of those creases, there can be accumulation of saliva, which can lead to growth of microbes in that area. Nutritional deficiency, like various B complex deficiency or iron deficiency anemia, angulocheilitis is a common finding. Then diseases of skin like psoriasis and other factors could also be there, which can lead to angulocheilitis. The clinical features include characterized by a feeling of dryness and burning at the corner of the mouth. Triangular area of erythema and edema can also be there on both angles of mouth. Raggeds or linear furrow or fissures radiating from the angle of mouth could also be there. So these are the various appearances of angulocheilitis the patient can have. Next is the chronic hyperplastic candidiasis. This is the only type of candidiasis which has white areas which are non-stable. If you remember the thrush or the pseudomembranous type, those type had the whitish areas or curd-like areas which were scrapable. But this type is the chronic hyperplastic candidiasis, will have white surface or the hyperplastic tissue which is non-stable. So chronic hyperplastic candidiasis includes a variety of clinically recognized conditions in which mycelial invasion of the deeper layers of the mucosa and skin occurs, and this causes a proliferative response of the host tissue. Candida leukoplakia is considered the chronic form of oral candidiasis, in which firm white leathery plaques are detected on the cheeks, lips, palate, and tongue, and all these hyperplastic tissue which is there seen in this condition are non-sterile. So the clinical features of hyperplastic candidiasis are as follows. It is mainly seen in the men of middle age and above, and in heavy smokers. It is firm and white leathery plaque, which is usually found on the cheek, lip, and tongue. Lesions may persist without any symptoms for years. It doesn't rub off with lateral pressure, which is a very pathognomic feature for this as compared to pseudomembranous candidiasis. Slightly white to dense white lesions with occasional cracks and fissures could also be there. Histopathologically, epithelial dysplasia is seen, which is superficial, And the micelle invasion of the deeper layers of mucosa and skin can also be there. So this is the only variety in which deeper layers of the skin or the mucosa is involved along with the epithelial dysplasia. Differential diagnosis can be leukoplakia or the hairy leukoplakia. Next is the chronic multifocal candidiasis. Now, chronic multifocal candidiasis is usually seen in immunocompromised individuals or in patients with predisposing factors such as ill-fitting dentures. So, the changes frequently affect the dorsum of the tongue and the midline of the hard palate, and these lesions are called as the kissing lesions. The commissural area could also be affected, like the angular cheilitis and the denture-bearing area, that is the mucosal surfaces of the palate. So, multiple areas involved in this type of condition. You can see the example shown in this slide. The palate is involved, the most common area of a denture stomatitis. Then the dorsum of the tongue could be involved, like the completely erythematous area over here, or the depapillated areas in the tongue, and the commissural area which shows the changes. Chronic mucocutaneous candidiasis, hypoplastic mucocutaneous lesions, localized granuloma, and adherent white plaques on the affected mucous membranes are the prominent lesions that identify chronic mucocutaneous candidiasis. And these are usually syndrome associated, which can be further categorized as the familial and the chronic type. The familial type is usually seen has a genetic predisposition, whereas the chronic type will persist for a longer duration in these patients. Now let's move on to the treatment of oral candidiasis. The treatment of oral candidiasis mainly involves removal of the causes. That is, once the predisposing factors have been identified, those predisposing factors needs to be corrected or removed. Then treatment can be done topically or systemically, and the treatment has to be maintained for 7 days. And the response to treatment in cases of candidiasis is usually good. So the topical treatment involves the clotrimazole, which is very effective very much topically. 1% of gentian violet can also be given to the patient, as gentian violet has shown to have antifungal effect. The certain preparations, they are available in the form of oral pasty. Even they can be given. The certain oral suspensions are also available. Apart from these, the topical creams and ointments of antifungal medications are also available. So the nystatin, ketoconazole, and clotrimazole are the ones which are available in the topical creams and ointment forms. The amphotericin B can be given. They are available in oral rinse forms. Otherwise, amphotericin B is given mainly intravenously for fungal infection involving multiple systems. Microstatic cream of 1 lakh units can also be given. Amphotericin B 0.08 milligram per kg 2 to 3 hourly in ointment for cream-based suspension is also available. The elixir containing both tetracycline and amphotericin B is also available, which can give you the both antimicrobial as well as the antifungal therapy. Rinses are available in the form of microstatin and 0.2 chlorhexidine solution. Chlorhexidine also has shown both antifungal and antibacterial properties. So even in oral candidiasis, 0.2% chlorhexidine solution can also be advised. Systemic treatment is required in case of extensive involvements, or if the patient is severely systemically compromised, and apart from oral area, even the other areas are also involved. So Nystatin 250 milligrams 3 times can be given for 2 weeks, followed by 1 troch per day for 3 weeks. And fluconazole 100 milligrams once or twice for 2 weeks. Itraconazole 100 to 200 milligrams daily for 14 days can be given, and ketoconazole 200 milligrams once daily. So, lastly, to summarize, candidiasis is one of the most common oral infections caused by the fungus Candida albicans, which is the normal commensal of the oral microflora. The infection can range from mild superficial mucosal involvement to fatal disseminated disease, in immunocompromised patients. Therefore, a better understanding of the signs and symptoms of oral candidiasis is essential, which will help to render efficient oral care. Early diagnosis and prompt treatment of oral candidiasis minimize the need for extensive dental care. Expected questions from this topic are as follows. There can be questions on enumerate predisposing factors in oral candidiasis, write clinical features of denture sore mouth, write the treatment of denture sore mouth, classify red and white lesions of the oral cavity, and discuss the oral candidiasis in detail, and classify oral candidiasis. Apart from these, the questions can also come on angular cheilitis, then atrophic candidiasis, and associated lesions. Any of these, the questions could be expected. These are the references. Thank you.